So Dr. James Morrow, a senior GP partner in the Salisbury Medical Practice in southern Cambridgeshire. Thank you very much for coming in.
A pleasure.
And first of all, can you describe your vision for an accountable care organisation?
Yeah, in Cambridgeshire we've got this idea that we would like to pilot or to be a demonstrator site for an accountable care organisation. And the key features of that really are that it's formed around a defined population base with a capitated budget for that, held by a provider-side organisation who's then held accountable for the outcomes, not the processes. So it's very much about transferring budget from commissioners to providers and asking the providers to deliver the outcomes that the commissioners want, but allowing the mechanism and the nuts and bolts of that to be dictated and decided really on the provider side rather than on the commissioner side. And it's about integrating primary, secondary, community services all together in one delivery unit.
And what made you think that developing an accountable care organisation was relevant in Cambridgeshire?
I think we've got some fairly unique geographical circumstances which mean that it's an ideal place to test this hypothesis as to whether this is actually a more effective form of delivering care. We've got effectively a large single foundation trust as the acute provider and a cohort of fairly stable patients around that, with a fairly cohesive general practice population of GPs and nurse practitioners and other clinicians delivering care as well. So I think we've got unique geographical circumstances which mean it's an ideal crucible to test it.
And what kind of advantages do you think it will deliver to patients in your area?
Ultimately, I think we're all motivated by delivering the best possible patient care for getting the greatest bang for buck. We've got a finite amount of money. We know that the needs and demands for healthcare are ever expanding, and I think by aligning the interests between secondary care and primary care we can actually achieve so much more for the same amount of money and produce better patient experience, move care closer to the patients where it's clinically appropriate, deliver greater satisfaction for those working within the system, and ultimately, and most importantly, provide sort of the best possible health outcomes for a population.
And how do you think that your local clinical commissioning group can help you to achieve this vision?
The commissioners clearly play a key role in this, that they have control of the budget, and how they decide to commission is very much that decision of that group. For the commissioners, there's some advantages in the ACO model. It allows them to focus actually on what are the outcomes they would like to see and spend time thinking about that and commissioning those outcomes rather than micromanaging and micro-specifying individual service provision pathways, which can sometimes, well, it's firstly very time consuming, secondly it can lead to a rather disjointed approach between different specialties doing different things at different speeds, and the interactions between those creating tensions and unaligned incentives. So I think the commissioners have a role to play to buy into the concept, to see the vision for a provider-side solution to their problems and allowing them to focus on what they should be doing, which is saying these are population needs, these are the outcomes we want to achieve, and specifying those along with the budget to get there.
And if that vision comes to pass, what impact do you think it will have on commissioning in the future?
I think commissioning is likely to become more streamlined, perhaps rather more strategic and rather more based around a needs analysis of a population rather than getting bogged down in the minutiae of ingrained toenails and warts and everything else that they currently seem to be preoccupied with. So I think it would lead to a more holistic overall assessment of patient and population level needs and free commissioners up from a lot of the mundane stuff that they currently find very bureaucratic and time consuming.
And in terms of things that if there are 2 or 3 things you could change to really enable you to make progress, what would they be?
I think firstly, at a policy level, I think we would like to see some sort of framework or encouragement from the Department of Health around enabling or facilitating demonstrator sites to take this concept forward. It's in the UK a relatively new and non-proven concept, although there's a lot of international evidence to suggest that it may well be a very effective solution. We'd like to have some central support to take this forward, to encourage the commissioners to be brave enough to commission something new, to provide some of the resources needed to create it, and help with the detailed analysis and monitoring of the performance of the ACO to make sure that it does deliver on our key objectives of better quality care at an affordable price, closer to the patients and with greater patient satisfaction.
And what are some of the barriers that you're facing now?
The barriers are a rather sclerotic, slow-moving, turgid environment where there's a long delay between a concept being promoted or promulgated and anything happening. The example that I use is in Cambridgeshire. We set up a community ultrasound service in primary care settings, and it took about 18 months from us taking this concept to the commissioners for them to approve it without any substantial change to the business case, the service offering or the delivery model anywhere along that line. But it was simply an iterative process going round and round multiple committees, and that was it was and remains disproportionate to the size of service being commissioned. So I think we need something that's going to be fleet of foot, the ability to make decisions rapidly, to implement decisions rapidly. And I think as a provider-side organisation, an ACO can do that, because it will be mainly about subcontracting services, not about commissioning them. And I think there will be a clear need, if one's going to work effectively and efficiently, to do that at the cheapest possible cost. And that means reducing bureaucracy, speeding up decisions, and evaluating things as they go along, rather than overanalyzing it before it starts.
And finally, if all goes well with the ACO, what might patient experience be in a couple of years' time?
I think the first thing to say is they probably wouldn't notice much difference to begin with. It'll still be the NHS delivering their care, but it will simply be that they'll notice that things are getting better, that rather than being sent off to a hospital to see a specialist to get advice about a drug, the GP will interact electronically on the single record and have the advice delivered directly to the GP surgery. Access for the patients to their own records, more services delivered in the community, a viable alternative to A&E by bringing diagnostics into community settings, supported by specialists with good clinical governance. And also I think perhaps a greater ability to take some time out from just doing the face-to-face stuff and spending time thinking about what are the interventions at a community level, in an educational level, or patient involvement level that actually will make a bigger difference to more people in the longer term. So I hope it will actually be just a better experience, a quicker experience for patients, and ultimately more patients living healthier lives for longer, without any change to the fundamental perception or experience of the NHS as a service that's delivered free at the point of delivery, according to the patient's needs, which is the one thing that we all subscribe to.